Okay, so I'm from the University Medical Center of Groningen in the Netherlands, but before I was working at MGH Boston, so part of the slides are from MGH. Groningen, it's in the Netherlands, in the north, and we got a pretty large center that treated 4,500 patients per year. We got 9 electile linacs, radiosurgery, orthovoltage, brachytherapy, around 80 patients per year, and we got 2 IBA Proteus Plus, which are the full gantry, 360. A little bit of a proton if you're not used to it, so we're using a cyclotron to accelerate protons. We got a beam line, so it's just a bunch of magnets, and after we're going to the gantry. So the gantry is our main issue for LNRT. So as you can see on the picture, it's 3-story high, it's rotating around the patient, and it's 70 tons, but it's sub-millimetric precision. The second issue for a proton center is you're sharing your beam. What that means is your patient may be ready for treatment, but you have to wait because your beam is used in another room. So you need to be able to track. A little bit about the technique, pencil beam scanning. So it's just a beam, a really few millimeter beams that you will move inside the patient, and you can define the depth, changing the energy, and after you can have a really high conformality of your target by moving the beam using magnets. So that allows us to use a single en-phase beam. So what does that mean? You can see on the picture on the DR that we're using only one field that will treat all the nodes plus the breast or chest wall. You can see that this technique was developed and checked against setup uncertainty. So we used initially 3 mm 2 degree. So if you look at the top DVH, the difference for setup uncertainty was mostly for the IMN. It's logical, it's a really small structure, so if you're like 3 meters off, you will miss your target. And the main constraint is also on the esophagus and thyroid. So it's not the main organ at risk, but we're still looking out for them. And we also check the technique against breathing motion, and you can see that breathing is not an issue for a PBS treatment. If you're not used to PBS, the hard dose is a little one at the bottom, and the long one is the yellow one on the curve. So we are sparing a lot heart and lung with PBS. A little bit back to the proton center. So we got a 60 patient positioner couch. We got X-ray imaging, so we got 2D KV, and CBCT. So for us, CBCT is pretty new. So there's only a few proton centers that use CBCT. And obviously, we got a surface image. So the issue that we have is this bulky gantry that rotate around our patient. So we can't have our camera on the side. And the main issue is that we're missing data. So if you look at the picture of the dummy phantom, if you're flat on the couch for breast treatment, you will miss a lot of data in the supraclavicular area. So what we did is we raised the breastboard to the maximum angle where we can feed the CT, and that gives us the data that you can see on the right. So that's the image that we got at 2 real patients that we had, small breast and larger breast. And you can see that around the neck, we're missing a little bit of the data. We can't do more, so we worked a lot with LNRT, and that's the best we can do, and it's already enough for us to position our patient. The second issue we'll have is the CBCT. So the CBCT use laser guards that are around the patient, and we got a lot of trouble with collision. So each time the system will detect a possible collision, it will stop. So we can't move the couch much. So we have to move the patient a lot to still keep the couch and everything so we can acquire the CBCT. So historically, how did we work? So initially we worked as most everybody, laser, tattoo, set of orthogonal X-ray until we were positioned correctly, and we are moving the gantry and finally check with the beamline X-ray. We were kind of one of the first users for LNRT in a proton center, and initially they asked us to use what they call gated LNRT. So we tried. So we replaced orthogonal X-ray by gating LNRT. And here what we got, so if you're not used to the capture gated, you have to select a point on the abdomen, and you're supposed to have a super nice breathing curve, so that's what you got at the top. But it happened that for a lot of patients, we never managed to have this super nice breathing curve. And you have to pick up one of the points of the curve, so they ask you to pick up the bottom one and check every day. So you're supposed to check every day the same breathing position of the patient. So the breathing curve didn't work that much, but the results were pretty good for positioning. So we were less than 3 millimeter 2 degree, which is our robustness for treatment. I need to precise that it was with an old camera system, and the acquisition time was a little bit too long for us, 30 seconds for each image. That was a little bit too much for the way we wanted to treat. So we switched to a non-gated treatment image and monitoring. And so initially we had the old camera, 2014, and we switched to the new cameras. And if you look at the red line, which are our tolerances with the new camera, we are definitely in less than 3 millimeters 2 degree. And in fact, we are even better than 2 millimeter 1 degree. So that's totally acceptable for what we wanted for positioning in a proton center. So after positioning with the line RT, we were like, okay, so it works, it's pretty fast. Do we still need to do X-ray? So that was the next question we asked, and we studied 28 chest wall patients. So we decided not to use the bony anatomy for the KV image, but to use the tattoos that we had at that time and to add markers. So we wanted to have shifts that were the same as what we had with the line RT. And we did that, and so we compared this shift, and we registered the one that were more than 3 millimeters off. And we found that it happened for 25% of our fraction. And when looking a little bit deeper on why did we have this shift for 11% of the fraction, it was mostly at the end of the treatment, so we assume swelling or changing in patient weight. For 3.4%, it was at the beginning, and in that case, we had to send the patient back to CT, and we found that it happens that we had a shift in the implant. And for the other 11%, it was totally random. So one day, we got a 3 millimeter shift, probably because maybe the BBs wasn't put correctly, or whatever reason, we never really found out. So we decided to keep the beamline X-ray, but only the 3 first days of treatment, and after once a week. So now, how do we work? So, as most of people, we import the RT plan, RT structure from a RAY station, and we're using the free breathing CT skin as our reference. So we are free breathing, we are not gated, just because we can't have gated PBS right now. It's coming, but for now, we just free breathing, and I don't even think we'll never do gated with PBS. That's my own opinion. But, and for the region of interest, so as I said, we are treating with the same beam, chest wall plus nodes, but we decided not to include all the nodes, mostly because they're in the neck and that's an area that move, and also we are not taking the armpit into the region of interest. So our first steps will be to get close to isocenter. So that's the first image. So we got a loading position for the patient. And after, we will send the couch automatically to isocenter. So we are not applying shift, it's go directly by the system. And we will simply check there that the patient is aligned at the right position on the breastboard, so we're using the rulers. And what we also do, and that's because historically, the RTT from the photon side were used to ask the patient to rotate their neck, but we're treating this area, so we wanted them first to remember, please keep the neck straight. And also, as you can see on the picture, we are doing the imaging inside the room. And when you do that, the patient has kind of tendency to look around and try to see what's going on. So we just want them to remember not to move their neck. So it's not an immobilization device, it's just a reminder for everybody. The CT is straight, please keep your neck straight. And we are acquiring what we call capture image. So the reason why we're not using monitoring is because we're using a smaller region of interest, but we also want to check the hips position, the arm position, and the neck position. And here an example, so you got this patient for which we take a really nice image. The translation are perfect, but she's got a 2-degree rotation. So we will never apply that on the couch, and we what we will do is check what's going on. So we are moving a lot the image, and we found out that this patient moved her hips on the side, so we will just manually move her back in position, apply the translation on the couch, and in the end, you will finally have a perfect positioning of your patient. The second thing that we're checking is the chin and the arm. So for the chin, we're using personalized head cap, and it happens that sometimes they use the wrong one, and that you can see right away. We also know that if you got more than 2D repeats, obviously they made a wrong decision from the head cap. And the second thing is we're checking the arm position. So there's different, so we're treating arms up, or we can also treat arms down if the patient can't go arms up, and we'll simply move the arm manually and acquire a new image. And after all that, we will still check that we got the straight move. And again, we are extremely limited, so we are doing mostly our move manually. And when everything okay, we will use the monitoring mode to check that the patient is not moving during the breathing cycle. So the next step will be, normally for most proton center, 2D KV. So here are some images, DRR versus KV. So that's the most commonly used. Some people use bony anatomy. I think like for a breast treatment, it's extremely difficult to use. The ribs are moving, the spine is way too far. So I'm used to use skin markers, but if you want to do that, you need to be able to put them every day at the same position. So you need tattoo, which we are trying to avoid. And it's a pretty small field of view. Compared to what we got with the LAN-RT, you can see the neck, you can see a little bit of the arm, but definitely not the hips. So CBCT, that's new. That's what I just said. I don't know any centers that do breast treatment with CBCT with proton. It allows you a precise repositioning of the breast. The main issue is our field of view is really small. So we need to think a lot of where we will put the isocenter. And as a lot of people talk in different presentations earlier, our isocenter is definitely not in our target. That's because of all the constraints we got with the CBCT. And also it's time consuming. So it's 1 minute acquisition, a few second reconstruction, and you need to analyze, and it takes a little bit of time. Okay, additional dose. So to conclude, we like Vision RT, LAN-RT, because of the large field of view. That's really one of the advantages that we found in the system. No radiation, and really fast. So you don't have to think and spend time reviewing the image, even if we're playing a lot with the image. The drawbacks of it, we got, and you heard it, this kind of phantom shift if you look at what happened during a gantry rotation. So you need to be really critical of what's going on and not just trusting the system without understanding what's going on. We had some issue with implant, and we didn't detect them with the LAN-RT. It's probably because you are using a small region of interest based mostly on the implant. And so we managed to perfectly align the patient, but when we were checking with KV, we found out that the implant had shifted. It's not happening a lot. We treated more than 100 patients, and it happened twice, I think. And the last issue we had was dark skin patients. So I think, from what I understand today, that it's just a configuration of your system. But we had a really dark skin patient that her skin was like desquaming a lot, and in the end, we couldn't almost see anything. So that's kind of difficult to say. Sorry, we can't position you today. So the last one, and I think that was the most important for us, so we are a proton center. As you probably know, we're pretty expensive, so we are really selective in our patient, and we are really limited in how many patients we can treat. So in the past, we were using X-ray. The purple one was the positioning, and the light blue is the treatment time. So treatment time is around 4 minutes. I think we're a little bit lower now, like around 3 minutes time, just one beam. And positioning initially with X-ray was, let's say, around 10, 11 minutes. So to be fair, that when your patient is ready for your first LAN-RT image to when the image that we acquired just before treatment. When we switched to a LAN-RT gated, it was better, but we were still like around 7 minutes positioning, which is good. But when we switched to a LAN-RT non-gated, we managed to go to around like 5 minutes, even less, 4 minutes. So in total time, for a breast patient in a proton center, we managed to treat around 10 minutes. 10 minutes patient go in, 10 minutes after patient go out. It's a lot for us. That means in a time that I treat like head and neck patient, I can do 3 breasts. And that's the way we count. So, and I just want to thank the UMCG. So we are working really hard to have breast ready. We will start the first breast in January. MGH for all the work they did on proton breast treatment, and University of Florida because they gave me some of their pictures. Thank you.